Let's start with where we all are, which is still reeling from the deaths, morbidity, and economic consequences of COVID. Here you see a global estimate from the World Health Organization of deaths from coronavirus, very conservatively estimated at 6 million globally, but highly conservative. And of course, the experience of this pandemic has been a deep reminder that you can't contain the spread of an infectious disease one person at a time. No individual can make themselves completely safe. But in fact, containing the spread of an infectious disease, particularly a novel infectious disease like COVID-19, requires a population-level approach. And that, of course, reminds us that we're all in this one together. And we're in together in terms of how we build responses to it, from strengthening health systems, using science to develop new diagnostic tests and therapies, figuring out how the infection is actually transmitted from person to person, what the drivers of this infection are, such as environmental issues like air pollution and climate change, understanding how it's varying from season to season, and predict the science of predicting what is happening, how it's spreading, where it's likely to go, and how this will roll out even now over coming months and years. And of course, not only is a pandemic an issue for collaboration within nations, but globally as well. So there have been a huge threat. There's been a huge threat to our well-being by every measure from this pandemic, and immensely inspiring capabilities and responses from science in so many ways. But there are many long tails of COVID. The immediate consequences that we are seeing declines in life expectancy in many countries of the world, and the ongoing health effects from what is being called long COVID as the disease continues to affect the individuals who had severe illness and perhaps even mild illness for months and concerningly possibly years after. The other long tails of COVID, I would say, are that this pandemic has exposed the risks from underlying ill health that people had before they were infected with COVID-19. The issues of the fact that compared to the 1919 pandemic, almost every country has a population that is living longer and with greater life expectancy than anyone saw in 1919. And so how our physiologic vulnerabilities develop with age and make us particularly susceptible to a novel infection like COVID-19 has been critical to understand, as we've seen dominant deaths in older people, but also deaths due to underlying chronic disease at any age, and vulnerabilities due to the social determinants of health and the resources that people have to develop good health or to protect themselves in the face of COVID. And of course, we've seen that drivers of ill health like air pollution and global warming also have elevated the risks from COVID-19 itself in terms of causing severe illness. We also have learned in the face of this COVID pandemic that, contrary perhaps to what some have said, that the health of the population and our economies and economic well-being are not separable. And we need to put those two together to understand future paths. And future paths involve the recognition that there are increasing rates of novel infectious agents in the world. COVID-19 is not an isolated instance, but over the last 30 years, we have been seeing an unprecedented rise in novel infectious agents affecting humans. Two of them are mentioned here. They include SARS, which emerged in 2002 in China, originated in bats and was transmitted to civet cats and then to people, and that caused countless deaths. and 8,000 cases and 800 deaths. And then MERS, which emerged in 2012, originating in bats, transmitted to camels, and then to humans. And of course, now in 2019, the emergence of COVID to the present. New cases continue to emerge of MERS, and we have seen over the last 30 years that these are, along with many other infectious diseases, that have had the potential to actually contribute to other pandemics, although thus far, besides COVID-19, they have been successfully contained. But COVID-19 is not going to be our last pandemic, because humans are increasingly being exposed to novel infectious agents, in part because of changes in the ways humans are living more close to animals that we're never exposed to before, and because of many other factors, including globalization. The global reports, and there have been a number, about how to learn lessons from this pandemic and prepare for the next ones, have concluded uniformly that we need to increase our investment in preparedness, both within nations and globally, and particularly to focus on how we promote the health and prevent underlying ill health for populations. And this is, in a lot of ways, I think, along with preparing for the next novel infectious agent, the two critical lessons from COVID-19 that we need to focus on. These data, coming from the World Health Organization, summarize for 2005 and to the present the relative proportions of communicable diseases, maternal and perinatal conditions, and nutritional deficiencies in the blue bars compared to chronic diseases, or what is called non-communicable diseases, in the orange bars, and injuries in terms of causes of death in low-income countries on the left, lower middle-income countries to the right of that, upper middle-income countries to the right of that, and high-income countries. And what you can see is that in the early 2000s, we passed the threshold where chronic diseases are the dominant cause of ill health and death around the world. And in lower middle income countries, that's absolutely clear. Low income countries still are juggling a huge double burden of longstanding threats to health, as well as the huge increase in chronic diseases and injuries that people are living with the consequences of for many years. If we look just at the US and India and how causes of death and disability compare, what you can see is that in the US, almost all of the causes of death and disability are chronic diseases of different kinds. India, of course, as you all know well, still has a mixture of longstanding issues in terms of infectious diseases, but now 4 of the leading causes of death and disability are chronic diseases: ischemic heart disease, chronic obstructive pulmonary disease, numbers 2 and 3, stroke, number 6, and diabetes, number 9. So this double burden is front and center for India, and of course, deeply affects the health of the population. And if we look at the US and India as 2 key exemplars of what the drivers of this death and disability are, 6 of the 10 drivers are shared between India and the US. Air pollution, high blood pressure, tobacco, high fasting plasma glucose, dietary risks, high body mass index, high LDL, and alcohol use are all shared across as drivers of ill health, death, and disability. Here you see a figure of the health conditions that reported by LASI, the Longitudinal Aging Study in India this year, the health conditions that older adults 60 and older report living with. Hypertension on the left, diabetes, and arthritis are the 2 major conditions that people live with, and often people are living with multiple diseases. Over the last century, and even in just recent years, I think that, and much of this has been accomplished through public health. We have seen dramatic declines in child mortality. In the last 30 years, it has dropped by 60% globally. We've seen dramatic declines in women dying from childbirth. Globally, that has decreased by 44% since 1990. Because of scientific investments, diseases like HIV are now a chronic disease. We have advanced the treatments of many infectious diseases, as well as our ability to diagnose them and contain the spread. And we have learned that what we call non-communicable diseases, chronic diseases like stroke and heart disease, lung disease, diabetes, about half of them are preventable. And in countries that have invested in prevention, we have seen significant declines in death rates. All of these have been accomplished by effective public health interventions delivered at the population level, as well as and complemented by targeting highly vulnerable communities and individuals, including for medical care. These are tremendous, tremendous advances in the health of the whole population, in which both the individuals who have survived and thrived have gained, but so has the society. And the consequences of that are profound. So I'd like to talk for a minute about what I mean by public health before talking about some of the metrics of the aggregate consequences of these investments. So Dr. Reddy, in his inaugural lecture, said that public health's role is to identify and influence the determinants of the factors that determine health for all of us at the population level, and to then enable impacting on health and disease for all of us as individuals. That can be summed up, and this is from the U.S. National Academy of Medicine, that public health constitutes the actions we must take collectively to create healthy populations and prevent disease, disability, and injury. And again, as Dr. Reddy has said so elegantly, health is a product of both science and society. So I'd like to give you an example of how we have carried that out around infectious diseases, noting that 100 years ago, the 1918 Spanish influenza infected more than a quarter of the world's population and killed 2.5% of those infected. Since then, what has happened? Well, I'll give you the example of polio. Let's think about polio and how it has demonstrated three types of public goods that have come from science and collective investment. The polio vaccine, of course, was the work of a single scientist. In the global public goods language, we would call that a single best effort global public good. That vaccine has then been deployed globally in what we call an aggregate effort public good in order to eradicate polio. And we are so close across almost every country of the world, down to the last 1% of cases, which has been called the weakest link global public good. Now, this has been going on now for 50 years, the eradication of paralyzing, highly infectious disease. And now we see similar needs conceptually for preparing for the next pandemics. Methods everywhere from disease surveillance to tailored and effective prevention and treatment. And again, we'll need to accomplish this through these three types of global public goods. Innovation for diagnosis, vaccines, and therapeutics, and aggregate effort in terms of financing and governmental approaches to delivery and corporate approaches to delivery of these advances. And finally, recognizing that the weakest links are among the most vulnerable. and how we learn together how to deliver the capabilities to protect human health will require new approaches to educating the public and enabling people to understand the value of these interventions. So these are some framings of what we've learned, certainly from the prevention and containment of infectious diseases, as classic cases of what we all do together. And what we have done across the other issues that I mentioned has required similar variety of public good approaches, generally led by public health, to decrease deaths in childhood, deaths from childbirth, deaths from HIV and other infectious agents, and to increase the prevention of chronic diseases. And what have these all added up to? Well, I think the metric that best exemplifies what we have accomplished through our societal investments is that we have increased life expectancy around the world over 30 years in the last half century. And in the last 100 years, it started 100 years ago in the West and in Japan. 25 of the 30 years of increase that we are seeing in the people's life expectancy is attributed to the public health investments in the arenas that I've already described and many more. And what does that look like? Well, here is global life expectancy. Sorry that the title ended up on the left-hand side. Here from the increase from 1950 to 2022. In 1950, the global life expectancy at birth was about 45 years, and now currently it's 73 years. An astounding increase due to societal investment in the health of the population. We see this in almost every country. Here for the US, you see a less dramatic rise since 1950, but a similarly dramatic rise over 100 years. And here in India, look at the increase in life expectancy. In 1950, life expectancy at birth was almost 35 years, and now it's over 70 years and still rising. Again, an astounding increase in just 70 years. Here, a 40-year increase in life expectancy because of the investments in public health and then education and medical care. So I'd like to conclude by talking about both how does society invest in delivering the conditions that support health, and what are the arguments of the essential role of public health in this as a public good. So here you see a diagram from the World Economic Forum in which they pointed out and I was part of developing this, so we pointed out that every sector of society contributes essential elements of whether a population is healthy. You don't need to read the small print here, but you can see that if you go from top right clockwise, healthcare environment, the physical environment, the political environment, the workplace environment, the educational environment, the social environment, and technology and media environments all contribute, all have vital roles in whether a population is healthy or not. And this requires a whole of society commitment. Next slide. And how health gets delivered varies depending upon what the sector and issue is, from the socioeconomic factors that in fact are delivered broadly in society with the highest population impact and frankly the highest return on investment, to public health's role in changing the context of the situations in which people live and their opportunities for health, so that individuals' decisions about health can be made to choose the healthy options. The introduction of long-lasting protective interventions, often at a whole population level, and then clinical interventions and clinical counseling and education targeted to individuals who are at risk and need care. As you go from top to bottom, the population impact increases and the individual effort needed declines. These are This is a brief summary of the factors that create a population's health that was offered by Tom Frieden, who used to be the director of the U.S. Centers for Disease Control. But this aligns with what the World Health Organization and the UN have described as the determinants of health across all sectors: social, economic, environmental, and structural, and the wide array of social determinants of health, from income to the social environment, health system and services, housing, transport, public safety, the physical environment, whether people have jobs, and their education. And in the pandemic, we have now realized that broadband access is also critical. What's the role here of public health in contrast to medical care? Medical care providing care to individuals, often with the emergence of a clinical problem, and hopefully also delivering individually tailored prevention. A public health system is responsible for population-wide health through prevention and health promotion, delivered both for communities and the individuals and communities. The evidence is that, the labels disappeared here, but 60% or more of a population's health is influenced by the social, behavioral, and environmental factors that need to be created at a community and population level by public health. 10%, possibly 20%, comes from the right medical care, and 20 to 30% of health is influenced by genetics. So how much we effectively invest in the blue in public health and the delivery of the conditions that create health is highly determinative of the health people live with across the population, as well as whether they die early or late. So population health is, I am using the definition of public health, which takes responsibility for the health of the population. I'll give you some examples of how that can be delivered across the pyramid that I showed you. In terms of social determinants, access to education and safe housing, medical care. In terms of the context and the environmental exposures, everything from clean air and water and safe food to public safety and urban design. And the promotion of healthy behaviors and long-lasting interventions by public health, everything from immunization campaigns and smoking cessation and driving safety to actually assisting people in developing healthier habits and preventing, of course, the transmission of infectious diseases. Next slide. It's very clear that these interventions pay off. They're economically sound. Global analyses say, thinking about the social determinants of health, that achieving the Millennium Development Goals was estimated to yield economic benefits to the present of 9 to 20-fold from the investment. And global analyses looking for every dollar invested, for example, in water and sanitation, there's a more than 4-fold return in terms of lower healthcare costs. This emphasizes that the returns on investment cross sectors, which is another argument for why this is a whole of society decision to invest in health. If you look at family planning, the provision of family planning saves more than $4 on the complications of pregnancies. Higher levels of investment have much higher return on investment in terms of economic and social benefits of women and families being able to control the number of children they have. If you look at childhood vaccination, the 7 basic vaccinations of childhood annually save $43 billion in terms of medical care costs and ill health. And a child mortality prevention program can avoid 14% of the global burden of disease for a cost of $1.60 per person per year. People who are treated for depression and anxiety in the U.S. return $4 for every dollar invested in their better health and their ability to be able to work. So these are various metrics that demonstrate the value across sectors into society of investing in the conditions that create a healthy population. Next slide. Now, what we've learned from all of these, which I think is critical, is that science, I'm sorry, I skipped the slide. If you think about how using public health approach to America's approach to public health, or its definition of the roles of public health, you can also see, next slide, the same kinds of returns on investment in the US, an aggregate return on investment of 4 to 14-fold. And then specific investments, for example, in improving clean air, the benefit to cost ratio is 30-1 for society, reducing childhood exposure to a toxin like mercury, which is in air pollution. Huge return on investment over a period of 10 years. Anti-smoking campaigns, highly cost-effective. Drug treatment programs, highly cost-effective. But the challenge is that the benefits don't return to the place that made the investment, which is a classic issue of public goods. Next slide. So from these immense successes and the evidence on high return on investment to society, we have learned that science and evidence lay a basis for effectively improving health for everyone. We've learned that prevention works and matters at every age and stage of life, that investing in health for all has a very high return on investment to societies. Now, I would argue that this evidence, which is really relatively new over the last few decades, has led many countries to make a right to health a basic right of citizenship as part of its values and principles. And the question of whether health is a public good, I've tried to make the case that health is essential to both a person's well-being and their productivity, and the economic success and well-being of communities and nations. And also to make the case that ill health is produced at the societal and population level. In fact, estimates say that 70 to 90% of all disease and ill health risks are due to differences in the environments in which people live and the resources they have access to. So, next slide. So then another question would be, is public health, which delivers the conditions for health to everybody, a public good? And I would argue to you that it meets the definitions of a public good, that these are goods that are needed by everyone and make a difference for everyone. And most effectively, in most cases, delivered to everyone at a population level. That delivery at scale to entire communities or populations are highly effective, safe, and cost efficient. But they also have two elements that define public goods. That delivery to some cannot be exclusive. You can't create clean air just for people who have the resources to pay for it. If you create it, everybody gains and no one's excluded. And different people are not in competition, so it's non-rivalrous for being able to benefit. And the return on investment is high. Next slide. So again, the principles of public goods is that once provided, no one can be excluded from consuming them. And one person's consumption of them does not prevent anyone else's. For example, reducing risk of infectious disease incidents. The challenge here is that when everybody benefits but no one profits, there's no commercial incentive to produce these goods because enjoyment cannot be made conditional on payment. That without strong public support, civic support, and special interest support, it is highly unlikely that public goods will be underprovided relative to the benefit that could be accomplished. And in fact, next slide, we see that around the world. If we look at the proportion of government and compulsory spending schemes invested in health, I told you before that 60, maybe even 70% of a population's health comes from public health type population investments in health. But in contrast, on average, countries spend less than 2.5% of their health budgets in public health. So that is a key exemplar of the concern that public goods tend toward being underprovided. Now, most goods are private. People pay for them. And they don't get them unless they pay for them. And once they've consumed them, they have to buy them again in order to consume them again. So this is not an argument against private goods. That is our fact of life. However, the father of capitalism, Adam Smith, in 1802, said that there are certain goods which, though they may be in the highest degree advantageous to a great society, are of such a nature that people can't profit from. And that no individual or small group of individuals would have the resources to pay for them, nor would they get repaid. And therefore, we can't turn to individual subgroups or specific entities or corporations to provide public goods, because the profit is not there and the cost is high, even though the return on investment is even higher. There's also what's been called a free rider problem, and this comes from David Hume in 1735, which complements Adam Smith. There are weaker incentives for private provision of goods which could be called public goods because their benefits can't be made excludable. And at the same time, because no one can profit, there's an incentive for an individual to, quote, free himself of the trouble and expense and lay the whole burden on others. So on the one hand, there are a lot of drivers of why we see huge underinvestment in public goods consistently across countries, huge evidence that we need these as public goods. Next slide. And for centuries, national public goods have been part of the economic theory of government, because people-centered societies need a wide range of publicly supplied goods. Historically, we've thought about that as parks or transport. Increasingly, I think we need to think about health as that kind of public good. And that society needs government to overcome the failures of the market that Adam Smith describes so well, to provide the collective goods the society needs. And government, of course, is the actor that is the provider of public goods, often increasingly in public-private partnerships, but leading on the supply of those collective consumption goods that are fundamental to people's well-being. The other issue that's going on that amplifies the concerns about our underinvestment in global public goods is globalization. So we have seen in this pandemic that communicable diseases spread more rapidly in the face of a globalized world, along with antibiotic resistance. That global factors like climate change are changing disease patterns and vulnerabilities to disease. That environmental degradation is reducing access to clear air and water, not just locally, but globally. And that trends in a globalized world of health technologies being patented create artificial excludability so that people don't have access to these uniformly. In fact, in our globalized world, there are a number of global threats to health and sustainability that you could think of as public bads: antimicrobial resistance, increasing pandemics and other emerging infections, global climate change and its effects on health and environmental degradation, global food systems, risk factors for non-communicable diseases, and whether we'll be living our longer lives healthy or ill. And the issues of patenting, all of these are global threats to health and sustainability, which no one subsector of society can solve. And you could call these global bads. So global bads are exemplified by policies patenting and price inflation that makes necessary medications unaffordable, and lack of production of essential medicines because they're not profitable, even though we know how to do it and know people need them. Other next slide, public bads, you can think about antimicrobial resistance. In the US, A third of pneumococcal infections are currently resistant to the antibiotic of choice. And this brings the general death rate from bacterial pneumonias higher than what it was in 1918 before we had antibiotics. Next slide. You could think about public bads of health being disease from globally spread causes, warming, pollution, food insecurity, all things actually created by human society, which now we need human collective solutions for. Next slide. I'll end with a few examples. Pollution. Let's think about air pollution. The number 4 cause of death globally. 7 million premature deaths in 2016 due to air pollution. 91% of the global population is living in conditions of ambient air quality that exceeds recommended levels for health, well-being, and survival. And in fact, 14 of the 15 most polluted cities in the world are in India. And air pollution, of course, is a cause of global warming and also worsened by global warming. So an extreme threat to health that requires collective will and I think needs to be understood as a public good. Next slide. Now, we've seen in the pandemic that because of lockdowns, air pollution decreased dramatically and so did deaths. In China, there were 24,000 premature deaths estimated to be averted because of the decline in PM 2.5 during lockdowns. And in Europe, over 2,000 premature deaths similarly averted. So you could think about controlling air pollution as a global public good for both health and sustainability. Next slide. If you think about global warming and heat emergencies, Ahmedabad has implemented an exemplary public health-led heat action plan to protect people's health when in conditions of extreme heat. This too, I think, is an exemplary public good. Next slide. If you think about threats to food security in the future as a critical part of global health, global warming itself is worsening food insecurity as a result of droughts, deforestation, and the decrease in the nutritional content of foods. And global food production is going to need to increase more than 70% to meet the needs of a global population, which is rising. Next slide. And in fact, on top of that, climate change extreme events are threatening to cause dire issues of food insecurity and hunger by 2050. In fact, recent estimates are that in South Asia, the amount of food required to offset such an effect is triple the region's current food reserves. Next slide. So we need to prepare for a huge number of incoming issues, which require collective solutions. And as Beth said in 1999, a globalizing world requires a theory of global public goods. I would add that it requires a commitment to investing in their solutions. So investing in global goods of health, why I think it matters to make this all explicit. It's because the threats to our health, we now know are highly human created. And we highly know human control using science and delivery through effective and adequately invested in public health can actually protect human health in the moment and invest in everybody's future health. So these are critical common challenges that affect all of us. That your being ill undermines my future, and we're all in this one together, and vice versa, of course. And that investment in elevating the future of health is a prerequisite for sustained future progress for both rich and poor countries, and vital for the reduction of poverty and inequality. And this will require both national investments in every country of increased investment in the public good of health and the public good of science for health and the public good of public health. Next slide. Next slide. Oh, sorry, you did it. So national governments have to provide critical public goods at the national level. We also need to wrestle and pandemic control and preparedness is a key obvious focus how we build global public goods to prevent us in the effect of everything in the face of the global health challenges that are threatening all of us. And in fact, global public goods have the element, I would say, across countries that they have within countries of being non-rivalrous and non-excludable. Next slide. So I'll end with these two thoughts, that health, public science, and public health's provision of health and the prevention of disease, disability, and injury across the life course are essential public goods that require civic understanding and collective investment to secure for everyone, which will raise the future of all of us, of every community, every population, and are necessities that we bring human science to the creation of human health in the presence of threats to human health, which are increasingly human-created or human-preventable. Next slide. And I'll end by saying that if we invest in preventing disease and promoting health across the life course, using what we know now as well as what we will learn in coming years, we have the opportunity to do the unthinkable, to add to the immense victory of children living now longer lives, the opportunity for them to live those longer lives with health, and create the opportunity of healthy longevity for everyone.